Respected judges and my dear friends, this is a case report on massive blood transfusion. It goes like this. 47-year-old male patient with history of abdominal swelling of 1.5 months duration diagnosed to have gastrointestinal stromal tumor. Since it was a rapidly progressive disease, he was planned for surgical resection. And the CT scan revealed a huge soft tissue mass involving the peritoneal cavity extending from the subhepatic region to the pelvis with multiple lymph nodes. And for his investigations preoperatively, everything was normal except for hemoglobin of 6.5 gram percentage, which was corrected to 9.9 gram percentage by giving 3 units of PRC. On exploratory laparotomy, he was connected standard monitors, 18-gauge IV9, 7-French triple lumen central venous catheter, and plan of anesthesia was balanced general anesthesia with thoracic epidural analgesia. A large tumor adherent to the bowel, mesentery, bladder, peritoneum, and the sigmoid column was found on laparotomy. Between 11 a.m. to 2 p.m. on that day, while the tumor was being removed, his systolic BP suddenly dropped from 120 mm of mercury to 80 mm of mercury. He was having tachycardia, CVP of 2 and ETCO2 suddenly dropped. We transfused him with 1 liter of colloid and the surgeon complained of a diffuse massive bleeding from the tumor pedicles. In addition, 2 units of single donor plasma was given. Between 2 to 2:30 p.m., his BP fell again. After the removal of the tumor, the row area started bleeding torrentially. His heart rate was 122 per minute. His CVP was less than 3. Compression over the bleeding site and suturing of the peritoneum was tried by the surgeon. We requested for blood and blood products at that time. And at 2:30 p.m., we went into bradycardia of heart rate of 30 per minute. We gave injection atropine 1.2 milligram IV. He was revived. He had already exceeded the maximum allowable blood loss, and over the next 2 hours, we gave 6 units of PRC and FFP, 2 units of PRP, and 4 units of STP. His serum calcium was 6, which was corrected. Between 3:30 to 4:30 p.m., his BP picked up to 100. He was oliguric. He was put on Lasix and dopamine. His BP was 90/70, and urine output was improving. He was shifted to ICU for elective ventilation. Now, coming to the blood loss that he incurred, his maximum allowable blood loss was 670 ml, but he took total of 82 mops fully soaked with 2 liters of suction bottle, and total blood loss was 6 liters. Between 6 to 11 p.m. in the evening, his hemoglobin dropped to 5.2. We gave again 4 units of PRC, 4 units of STP, and cryoprecipitate 2 units over the 5 hours. His ABG was normal. At 11 p.m., he was going in for gradual hypotension. His veins were increasing. The surgeons complained of an ongoing internal bleed. His BP was 50. He was having tachycardia. His hemoglobin was 6.8. We had to transfuse 4 units of PRC, factor cells, and 4 units of STP again. In the morning, he was again tachycardic. His hemoglobin was slightly improving. In an attempt to improve the hemoglobin, we again gave 2 units of PRC, 2 units of SSP, and his total drain amounted to 3.8 liters in the last 7 hours. His CVP was raised to 6 millimeters of mercury. At 7 a.m., he sustained a pulseless electrical activity. He went into cardiac arrest, and CTCR was given, and IV adrenaline was also given. And at 7:35 a.m., he was revived from the cardiac arrest. Return of spontaneous circulation was noted. His vitals were stabilized. At 8 a.m., he was better, responding to call 12 plus, but his hemoglobin was still low. Again, we had to transfer 6 units of PRC, and since the platelet was 62,000, we gave 3 units of PRC. Between 8 a.m. and 12 p.m., because of the massive transfusion, he was going in for DIC, and his fibrinogen was less than 100. We had to give 14 units of cryoprecipitate, and by afternoon, his drain decreased to less than 200 ml, and his bleeding was almost controlled. Injection tranexamic acid 2 grams were also given. So in short, he was given 78 units of blood over 22 hours on day 0, that is on the day of surgery, and as well as on day 1, next day of surgery. By 6 p.m. the next day, he was hemodynamically stable, and he was extubated at 7 p.m. in the evening. For the next 11 days, he was fine and he was discharged. So few words on massive blood transfusion. It is either the transfusion of 1 complete blood volume in 24 hours, or the transfusion of half blood volume in 6 hours, or transfusion of 1 unit of blood in less than 10 minutes. Now, coming to the problems anticipated with massive blood transfusion, it can be DIC, dysfibrinogenemia, thrombocytopenia, fluid overload, hypothermia, hypokalemia, transfusion-associated lung injury, acute tubular necrosis, citric toxicity, and hypocalcemia. These 4 were the complications that our patient had. Now, the important point here, what I would like to stress is that fluid administration during active hemorrhage is not the cornerstone of resuscitation in a massive blood transfusion. Because the dilution of red cell mass, it reduces the oxygen delivery, and it also contributes to the hypothermia and coagulopathy that ensues. At the same time, transient elevation of the BP causes disruption of the clot and reversal of compensatory vasoconstriction. At the same time, there can be bleeding which can further aggravate the hypotension. So they say early transfusion of PRCs, plasma, platelets and other blood products are warranted. Now this is the lethal triad of massive blood transfusion. Coagulopathy has to be addressed, hypothermia as well as acidosis has to be addressed. Coming to transfusion trigger, it's a numerical value of hemoglobin is irrational to consider transfusion trigger, but when there is an acute hemorrhage with evidence of hemodynamic instability or inadequate output delivery, we have to transfuse, and the use of a single hemoglobin trigger for all patients is not recommended. Coming to transfusion threshold during massive blood transfusion, in ASA1 patients they say if the hemoglobin is less than 8, we have to give packed blood cells. FFP INR more than 2, CP fibrinose is less than 100, platelets it is less than 50,000. Algorithm for acute hemorrhage, we have to give pressure to the open wounds, IV access has to be made, send blood for investigation, deliberate hypotension, SBP to be kept at around 80 to 100. Now crystalloids till bleeding is controlled, blood loss to be replaced by blood and blood products, and avoid hypothermia. Coming to the end point of resuscitation, we have to know that it is not normal vital signs, but adequate tissue and organ perfusion, which we can make out by mixed venous oxygen saturation, which is the most sensitive technique. Other emerging technologies being gas spectrometry, tissue oxygenation, intramucosal pH, acoustic blood flow, and shock volume variation. So the take-home message will be: arrange adequate blood and products. During active bleeding, blood and blood products are the cornerstone in the initial phase in a case of massive blood transfusion until the bleeding is controlled. Crystalloids and colloids can be used in the later phase. Calculate maximum allowable blood loss for every major case and aim for adequate tissue oxygenation rather than normal vital signs. It's said that blood transfusion is a lot like marriage. It should not be entered upon lightly, unadvisedly or wantonly, or more often than is absolutely necessary. Thank you.